Everyone, it is my indeed pleasure to welcome you all to Lipitas lecture series, a focused academic initiative by the Nexa division of Intas Pharmaceuticals. As healthcare professionals, we find ourselves at the forefront of constantly evolving cardiometabolic landscape. The burden of dyslipidemia and its cascading impact on cardiovascular outcomes continue to challenge us, especially in high-risk populations. This platform brings together the leading experts in cardiology to share evolving insights on lipid management. So, without much ado, it is my pleasure to introduce the chairperson for our today's session, Dr. S.K. Dwivedi, sir. Dr. S.K. Dwivedi is Director of Interventional Cardiology at Medanta, Lucknow, leading advanced cardiac care services in the region. He is having over 38 years of expertise in cardiology with deep skills in invasive procedures like coronary angioplasty and stenting. Dr. Dwivedi is specialist in device implantation, balloon valvotomies, structural cardiac interventions, and closure of intracardiac defects, including proficiency in electrophysiology and arrhythmia management. Dr. Dwivedi is alumnus of King George Medical College, Lucknow, holding degrees DM in cardiology, MD in medicine, and MBBS. Dr. Dwivedi is former professor and head of cardiology at KGMU from 1990 and reflecting a long-standing academic and clinical leadership career. He is also recognized as one of the Lucknow's leading interventional cardiologists with a prolific record of national and international publications. So with this, I welcome Dr. Dwivedi and I would request him to introduce the speaker for our today's session. So it's over to you, sir.
Thank you, Sandesh, for the kind words that you have just said. I welcome the delegates here to this very interesting session of talking or thinking about whether to start a high-dose statin or to treat the lipids to the target. And there is always a confusion. Some people go for lipids, the target of 76, 70 or 55 or whatever you deem fit, and others continue with the high dose. So to clear this dilemma, we have today a very proficient speaker, Dr. Jabir Abdullakuti, who's a senior consultant cardiologist and director of cardiovascular clinical research in Lizzie Hospital, Kochi. He has over 2 decades of experience in invasive cardiology with more than 500 angioplasties and diagnostic procedures annually. He leads one of India's largest cardiovascular divisions with advanced CCU, 4 cath labs and research facility. Not only that, he is academically very keen and he has been principal investigator in multiple landmark trials, that is global phase 3 or phase 4 trials like Engage AF, Examine trial, Odyssey trial, Cantos, Paradise MI, and many of them. He's also the founder and lead investigator of major Indian registries, particularly Kerala Atrial Fibrillation Registry, Kerala Acute Heart Failure Registry, GCHF Registry, and not only that, he is an author of numerous publications and textbook chapters. He's active in Cardiological Society, he's active in clinical research leadership role, and there cannot be a better person today to enlighten us with this confusing choice that we face in and day out. So without wasting much time, I do not want to come in between the listeners and the speaker. So here I welcome Dr. Jabir Abdullakuti. Over to you, Dr. Jabir.
Good evening. Thank you, Dr. Deveti. It's a pleasure being a part of this program where one of the senior most cardiologists in the country is the chairperson. And what I heard from Indias is that there are more than 2,000 delegates registered for this meeting. Today, we are going to discuss one most important factor, which has been a question in our mind for a long time. That is, whether it is a high-dose rosuvastatin or a high-dose atorvastatin, which is better regarding the outcomes, or is it a moderate intensity statin plus ezetimibe, which is better than a high intensity statin? It's because of only one problem, because Indians who are prone to develop diabetes And statin, of course, is a diabetogenic drug, but its diabetogenicity is much less problematic when compared to the benefit it can offer, especially in a secondary prevention. So, statin, which remains as the primary modality of preventive treatment, secondary prevention, as well as primary prevention of atherosclerotic cardiovascular disease. The benefit has been proven with umpteen number of randomized controlled trials in the acute coronary syndrome and chronic coronary syndromes, as well as the real-world registries. Next. Could you go to the next slide? Thus, today I'm going to discuss a study known as the North Star study. We never had any direct comparison data between rosuvastatin and atorvastatin in acute coronary artery disease. And there is an uncertainty about which one among them offers a better cardiovascular protection, because we don't have any head-to-head comparison studies, except a few real-world data from India. And is there any difference in the diabetogenicity between the two drugs? Of course, we have proven or data which tells that the intensity of the statin therapy is also proportional to the diabetogenicity. Higher the intensity of statin therapy, more the diabetogenicity. And most of these evidences are from the Western trials. And we need a robust trial evidence to guide the statin choice and dosing, and whether it is high intensity statin or it is treat to target. Is the target important or the dose important? Next slide. I'm not seeing the slides. Could you show the slides? Go to the slideshow.
Is the slide visible to you now, sir?
No. So when you use a high intensity statin, that is 20 to 40 milligram of rosuvastatin versus 40 to 80 milligram of atorvastatin, what it basically does is the high intensity statin reduces the LDL cholesterol by 50%. And if you look at the treat to target, the current target is 55 milligram per deciliter in established ASCVD. And for a primary prevention, it's less than 70 milligram per deciliter. And with recurrence of events in ASCVD, it is less than 40 milligram per deciliter. These are all Western guidelines, basically the ESC guidelines. The Lipid Association of India guidelines is much lesser target. In recurrence, they consider it is less than 30 milligram per deciliter. So high intensity statin simplify the therapy because it's one dose of statin. But there can be problems of muscle symptoms, diabetes, lead to target. We don't have to use these high intensity statin, right? High dose in every person. It will be tailored one. That dose that is required to keep the lipid at target levels. It may not be the highest dose in every person. And now we have option of combining a moderate intensity statin plus ezetimibe to reach the target. Next slide. And go to the next slide. Okay. The fixed high intensity statin means it's likely to produce a 50% reduction. That is expected to produce a 50% reduction in the statin therapy, regardless of the baseline. And that's target to treat. If you are treating to the target, it has significant DL goals, balancing efficacy and safety. The high intensity simplifies monitoring, with the target request, serial LDL testing and dose adjustments. And both approaches reduce LDL cholesterol and subsequent cardiovascular risk. The choice depends upon the patient's risk, the tolerance, and the availability of the resources. Next. So high intensity statin, but it requires, if you look at the high intensity statin, there is less need for a regular or frequent lipid monitoring. But of course, as I have already mentioned, there is an increased potential for side effects. And there we have definite strong evidence-based supports the mortality benefits and the morbidity benefits. Next. So the treat to target strategies, or current target is less than 55. It may start with moderate dose, but in acute coronary syndromes and high-risk patients, high-risk atherosclerotic cardiovascular diseases, it should be the high-intensity statin to spray them. And if you are looking at the treat to target doses, you have to frequently measure the lipids at planned intervals. Here, there is a lesser chance or a lesser potential for side effects, but it is more resource intensive due to the regular monitoring and dose adjustments, and of course, more hospital visits. It's suitable for the CAD patients with variable LDL response. Next. So the rationale for a head-to-head comparison between these two strategies. It gives a practical insight for clinicians. Both these strategies, actually, the high intensity statin once the I think it is the guidelines before the current guidelines, AHA, they have said that they came to a conclusion that it is the intensity of the statin therapy and the fixed dose statin therapy rather than looking serially, and even they consider there is no need to look, there's no need for even a serial lipid estimation. A direct comparison informs us regarding the personalized care and the guideline detection. And LOTSAR is a study which fits this evidence in the Asian CAD patients. And I will remind you, this Asian doesn't mean Indian. This study is an exclusive study in the Korean population. Next. So the new onset of diabetes in statin, if you look at the statin increase, the new onset of diabetes goes by 9 to 12%, and the absolute risk increases by around 1% per year. And 10-year diabetes incidence can reach up to 36% in patients who are on statin versus 20% who are on off statin in the clinical trial. And this risk is higher in those patients who are prone to develop diabetes, like those patients with metabolic syndrome, family history of diabetes, obese patients, and other multiple risk factors. But those statins are diabetogenic. The cardiovascular benefits definitely outweighs the risk of diabetes. Next. So the association between intensive lipid-lowering therapy and the incident diabetes, you can look at it. As the intensity of the statin therapy increases, the chance of diabetes also increases. So it all depends. When we compare the 10 milligram dose, the chance of development of diabetes is much higher at 80 milligram of atorvastatin. So 13% and 29%. Sandeep? Okay. And Asians, as we know, the Indians, it's a genetically, we are more prone to develop diabetes. Southeast Asians are also, when compared to the other parts of the world, they are more prone to develop diabetes. For Asian Indians, 3 times higher diabetic risk. The prevalence is close to 8%, and the pre-diabetes is close to 10%. This is because of its high visceral fat, abdominal obesity, insulin resistance. And the Southeast Asian develops more new onset diabetes than the Westerners. Next. Lodestar trial, this is treat to target or high intensity statin in patients with coronary artery disease. It is the first randomized trial comparing 3-year clinical outcomes of rosuvastatin versus atorvastatin in patients with coronary artery disease. This includes ACS as well as chronic coronary syndrome, the all-comer population. The background, I think we have already discussed the background. You can go to the next slide. This is investigator-initiated, multi-center, randomized clinical trial in South Korea. Between the years 2016 to 19, this compared the efficacy between safety and efficacy of two statin treatment strategies, secondary prevention. And you should understand their target was less than 70, not the current target of less than 55. 2,400 patients with clinically diagnosed CAD, 2 into 2 factorial randomization at 12 centers. It is open label study, so the study has its own limitations, but it followed for over 3 years. But this is the largest data available so far. Next one. The patients clinically diagnosed with coronary artery disease, so anything, stable angina, unstable angina, instable or STEMI. And excluded patients are those pregnant patients, women of childbearing potential, hypersensitivity of statins, who are on drugs which are strong inhibitors of the cytochrome P450, and patients with risk factors for myopathy, hereditary muscle disorders, hyperthyroidism, and those with a short life expectancy and who could not be followed up for more than a year. Next slide. So it is 2,204 in the rosuvastatin arm and 2,196 in the atorvastatin arm. The primary endpoint is a composite of all phosphate MI stroke or any coronary revascularization. Next. You can see that rosuvastatin and the atorvastatin group. The age means 65 years. Female, it is close to 30%. Diabetes, it's only 33%. See, in Indian patients, it is maybe a little more. And the hypertension is much more, close to 68%. And previous PCI is 6%, CABG okay. So in the Lodestar trial, approximately 11% of the patients received ezetimibe as an add-on therapy. And this was more common in the treated target group rather than in the group where high-intensity statin was tried or high-intensity strategy was tried. Next slide. And the primary outcome, as I've already mentioned, death, MI, it's all cause MI, stroke, coronary revascularization. The secondary outcomes include the new-onset diabetes, hospitalization for heart failure, venous thromboembolism, peripheral artery revascularization. And the key outcomes from the treated target group versus high-intensity group. You can see the mean LDL cholesterol, not significant difference. And the portion of patients with the target LDL achievement of less than 70 milligram per deciliter, 52.8% in the treated target group and 59.7% in the high-intensity statin group. And then the short term, that means 6 weeks and 3 months. If you look at the 6 months and 3 months in the 6 weeks data, a higher percentage of the people in the high intensity statin group would achieve the target LDL. Primary endpoint, no difference. All-cause mortality, no difference. Myocardial infarction, stroke, nothing. Statin intensity is 3 years. Only 56% of the treated target group were on high-intensity statins, but on the high-intensity statin strategy, close to 90% on high-intensity statin therapy. Next. And when you look at the secondary outcomes, one interesting thing, or rather it is expected, rosuvastatin lowered the LDL cholesterol better than the atorvastatin, but the absolute difference in the LDL cholesterol is not that different. But the proportion of patients achieving the target LDL cholesterol was higher in the rosuvastatin group. New onset diabetes was 7.2% with the rosuvastatin and 5.3% with the atorvastatin. And cataract surgery also 1% higher. High-intensity statin therapy at 3 years. In the rosuvastatin group, it is 71%, and in the atorvastatin group, it is 74%. And statin intolerance, almost equal, not much difference between rosuvastatin and atorvastatin. Next. And the use of ezetimibe was then seen 11% of the patients. Ezetimibe was added to the statin therapy, much more or mostly in the strategy. Yeah. And the lipid lowering, which was higher degree of lipid lowering, was consistently seen with rosuvastatin when compared to atorvastatin. And see, it's 62, 66 at 3 months, and the 62.5% versus 55.2% at 5 years. Rosuvastatin is, of course, a little more potent drug than the atorvastatin. Next. And in the subgroup analysis for the primary outcome, but regarding the clinical outcome, there was no difference between these two drugs. Next. And if you look at the statin type and the risk of new onset diabetes, you can see higher the intensity, you can see this graph.
Dr. Jabir, you are on mute.
Dr. Jabir, you have muted
Oh,
yourself.
okay.
Now it's all
Sorry.
right. It's all right.
Right. Okay. If you look at that graph, you can see the difference between the rosuvastatin and the atorvastatin. Those patients on rosuvastatin, they had a better LDL cholesterol control, but at the same time, they had higher incidence of diabetes. That Next slide. Sandesh, could you move to the next slide?
Yeah, I have moved to the next slide, sir.
Right. So the key takeaways from the Lodestar, there is no significant difference in the clinical outcomes. Better mean LDL cholesterol achievement by rosuvastatin across 3 years. And the treat to target LDL cholesterol approach was not an inferior one to the cardiovascular, to the high intensity statin therapy regarding the cardiovascular outcomes. In CAD patients on high intensity statin, overall new onset diabetes was similar between rosuvastatin and atorvastatin, but the difference emerged when you look at those patients who achieved LDL cholesterol less than 70 versus more than 70. Next slide. So what are the clinical implications of this South Korean trial? Patients have higher susceptibility to diabetes, and high intensity statins are quite effective regarding the cardiovascular protection, but it elevates the diabetic risk. The treat to target strategy of a similar cardiac protection with potentially lower metabolic risk. Of course, we may require a larger study targeting the current target of less than 55 milligram per deciliter in Southeast Asia, in the Indian population also, to make a definite comment on it, because this is exclusively in one ethnic population. And during statin therapy, especially those patients who are prone to develop diabetic or pre-diabetic or who have diabetogenic factors, we should constantly monitor them for the metabolic parameters. And the patient-centered decision making is important to make the balance the benefits and safety. So this study gives us a thought process and insight regarding whether we should change our strategy in the treatment of a subgroup of patients or a group of patients whose diabetogenicity is higher, whether it is blindly high-intensity statin therapy or it is treat-to-target therapy, especially our obese patients who are not diabetic, obese patients, or those patients with family history of diabetes who have atherosclerotic cardiovascular disease. Next. And Asians, if you look at the pharmacogenomics, they have higher plasma statin levels, and our LDL cholesterol reduction per milligram of statin is much better or more when compared to Western population. Our statin related adverse events are high. And the CYP at 345 and the ABCG2 transporter variants influence statin metabolism. So our statin threshold may be lower, and it may help to avoid the toxicity. An individualized approach may be a better one in the Indian population. This is a wishful thought process. Right now, we don't have any definite data to support this in Indian population. This lodestar data is in the South Korean population. So how do statins produce diabetes? So statins, I think this these things, everybody knows it well. The mechanism of action of statin, the reduction in the so the HMG coenzyme reductive synthesis, reduction in the cholesterol, the LDL receptor, increased LDL receptor activity, more LDL upregulation, more LDL uptake, and reduction in the LDL leading on to benefit, and the so-called pleomorphic effects, the high intensity statin which produces the early effect and perhaps the plaque stabilization. Next slide. So this is now the possible mechanism of statins, mechanism of diabetogenicity by different pathways through activating different mechanisms. It reduces the insulin secretions. It decreases the insulin sensitivity, leading on to type 2 diabetes. Next. And the ethnic predisposition to this diabetes is higher for the Asians because of the high visceral adiposity, high hepatitis steatosis with a lower BMI, and our beta cell contributes to a faster onset of diabetes, and of course genetic variants and lifestyle. And in such a population who are prone to develop diabetes, statin-induced diabetes may be higher. And the data also shows that statin-induced diabetes and statin-related adverse effects are more in the Asian population. Next. And the high-risk individuals like pre-diabetes and obesity are more to develop vulnerable to develop new onset of diabetes. So the North Star data says, what it tells us is that if you go titrate according to the need to keep the LDL cholesterol at or below the target, there are a good number of patients who may not require high intensity statin, rather they may require a moderate intensity statin or a moderate intensity statin plus ezetimibe. Prevention of type 2 diabetes may require overdose statins and adjuncts like ezetimibe. So individualized therapy, especially in those people who are diabetic. Next. So summary, the analysis comparing rosuvastatin from atorvastatin in the North Star trial. So this we have already discussed. The primary endpoint in the diabetic group. You can go ahead. We can look at the comparative guidelines since 2018 AHA. Fixed high dose intensity, fixed dose of high intensity statin therapy to all those with established atherosclerotic cardiovascular disease and very high ASCVD risk.
Let us hope that Dr. Jabir comes back online. Till that time, what he was discussing was a Lodestar trial, which compared the strategy that we had earlier discussed, whether to fix a target and then go on increasing statin and keep checking the LDL levels, whether it has come to target or not. Whatever is the target, be it 70, be it 50, 55, be it 40, whatever is the target. Or the second approach is load and forget. That means start high dose and forget. Now, what are the most important aspect that one has to understand here is that the Lodestar trial said that in patients who are already known to have coronary artery disease, both these strategies of high dose atorva or rosuvastatin or goal directed strategy did not have significant difference in primary endpoint. That means whichever approach you want, you can take, and it will not change the outcome as far as the endpoints are concerned. However, this was the primary outcome, and what we are worried, what we are generally what we want to take from the trial is what is the primary endpoint. Primary endpoint was whether the endpoint is different or not. So it gives us a message that you can start either of the strategies, not necessarily high dose, but if you go for the target oriented approach, which generally will be a lower dose, so that is good enough. There are a few points which need to be understood while discussing Lodestar trial. Now, the trials of high dose statin has been tested in patients who are either on placebo or on high-dose statin. That means those patients had not received statin earlier. They were randomized to receive high-dose statin or placebo. And high-dose statin showed a remarkable reduction in outcome, combined endpoint, mortality reduction, stroke, MI, and revascularization. In Lodestar, these patients were not naive. Nearly 80% of these patients were taking already either a moderate dose statin or a high dose statin. In fact, statin naive patients were only 20%. So, actually, these were patients who were already on at least moderate or high dose, 80% patients. This may have resulted in dilution of the efficacy of statins. And that is seen also. If you see at the end of 3 years, the event rate is 8.5% roughly in both the arms. That means about 2.6% per year. And if you go for mortality at the end of 3 years, the mortality was 2.5%. That means 0.8% per year. And when they planned this trial, they decided the number to be 4,400 based on the speculation that larger statin trials have shown an outcome of about 12 to 15%. So they thought that there will be at least 12%, and this trial was powerful enough to answer the question if the event rate was 12%. But here you see the event rate was 8.5%, primary endpoint. So from that regard, Lodestar was probably not strong enough to find out the difference between moderate or let us say treat to target and high dose statin. Because patients were already taking. One can also say that since they were already taking high dose and moderate dose statin prior to being randomized, the event reduction would already have taken place in past. That is why the events are not that high. So here is a catch in this trial, that should we take the results as they appear. Secondly, he was very right, and we all know from two large meta-analyses. First was published in Lancet in 2011, 90,000 patients of statin, and they came out to have a risk of about 9% extra diabetes in patients who are taking statins. Another meta-analysis published in JAMA in 2011, which tested moderate or high dose intensity and possibility of new onset diabetes, and that was found to be about 13 to 14%. So the premise is that with the high dose statin, there is approximately 13% more chances of diabetes. Now, this is a diabetes which is drug-induced diabetes, and we really do not know what would be the impact of this diabetes on the endpoints. Will it be same as that or diabetes which is acquired as, let's say, the type 2 diabetes mellitus or something else? We don't know that yet. And secondly, you can also predict which patient is likely to have diabetes. And there are 4 parameters. One is presence of metabolic syndrome. Second is a BMI of more than 30. Third is fasting sugar, not actually diabetic, but fasting is more than 100. And fourth one was HbA1c more than 6. That means these patients are prone to develop diabetes mellitus. So in those patients, one may be cautious because they are more prone to have diabetes. So you have to be cautious. Nevertheless, despite these drawbacks, Lodestar at least tells us that in patients who are having roughly a LDL of about 85, whether you use high dose statin or you use target directed therapy, there will be about 25% reduction. Since these patients are already taking statin, what happened actually? From 85 it came to 68 or 69 LDL. That is about 25% reduction. That means this is the effect of, it is not the 50% reduction which you expect in high dose statin. Why? Because they were already taking statin and some LDL reduction had already taken place. So that may be the reason why the trials did not, this Lodestar trial did not show the expected benefit or expected difference with the high dose statin as compared to. Another thing can be they also considered 40 milligram dose of atorvastatin as high dose. Remember, friends, the trials which have used high dose statin, none have used 40 milligram. It is only the guidelines that say that 40 or 80 of atorvastatin. No, high dose statin is 20 or 40 milligram of rosuvastatin, and the trials have used only 80 milligram atorvastatin. So if you had used 80 milligram atorvastatin, what would have been the impact? We cannot say. Majority of these patients, if you see roughly in the end of the trial, these patients will on supposedly high dose atorvastatin were taking about 38 milligram, which may not be the true high dose atorvastatin. So taking the trial with the implications of, yes, few things are clear. One is that there is not huge difference if you go for that. Why? Because the LDL reduction has been nearly the same. So that may not have resulted in translated cardiovascular benefits. And second is diabetes incidence is probably higher with rosuvastatin. Thirdly, if you are using 20 or 40 milligram of rosuvastatin, the LDL reduction will be more than 40 milligram of atorvastatin as a high dose statin. So these are the three things that come to my mind when I analyze Lodestar trial as been mentioned by Dr. Javed Kutti. So it is very unfortunate that we are missing him in the midst of the lecture. So these are the treat to target practical implications that have been shown. I think we have discussed it. And Dr. Sandesh, if there are any more questions or comments from the listeners or from the participants, they are welcome.
Right, sir. Thank you so much for pitching in at such a critical moment. And we're having few questions from audience.
Yes.
Yeah, just a second, sir. So there is a question, do you still prescribe high intensity statins for all post ACS patients, or do you tailor based on diabetes risk in such patient population?
Okay, so we have to understand what is the risk of acquiring diabetes and with the high dose statin, and what is the benefit of in reducing CV events. So roughly speaking, if you treat 1000 patients with high dose statins, you will be having probably new onset diabetes mellitus over and above about 9 patients, new onset. That means about 3 patients, and the benefit here is if you treat 1000 patients with high dose, you would be reducing about 30 events. So for one new onset diabetes mellitus, it is only the occurrence of diabetes mellitus, one new patient of diabetes mellitus occurrence at one hand equals to 3.4 event reduction. Event reduction means lesser number of death, MI, stroke, or revascularization. So the benefit of high dose statin certainly outweighs the risk. So that is why high dose statins, it should not deter us
Right.
from using the high dose statin. As far as if you ask my preference, all my patients who are diagnosed of coronary artery disease, either post-MI or by troponin-proven ACS, NSTMI, for that matter, who have plaques on 64 slice CT incidental finding, all my patients go on high dose statin. So I am a strong supporter of a high dose statin, preferably atorvastatin 80 milligram and 20 milligram at least of rosuvastatin if atorva is not the choice. That is how I take it.
Sir, I lost the connectivity in between.
Oh yes,
So-
we miss you.
Right. Okay.
We
Okay.
miss
But I
you.
think there were only few slides remaining. But you are into the crux of the matter. Your discussion is more important because this trial they looked at the dosage they looked at is 10 to 20 milligram of rosuvastatin versus 20 to 40 milligram of atorvastatin, not even up to 80 milligram of atorvastatin or 40 milligram of rosuvastatin. So the trial has its own limitations because of the Korean population, they don't use this much higher dose of statin as what we use.
Yes, correct. Ultimately, they ended up using about 18 milligram of rosuvastatin and 38 milligram of atorvastatin.
Absolutely, absolutely.
So
They
we can
use
say that if the difference is not there, if we are using, let's say, 20 milligram of rosua or 40 milligram of atorva. And that is what I was discussing, that 80% of these patients were already on moderate or high dose statin prior to being enrolled. So the difference may not have been there because they were already taking statins.
yes.
So we are not expecting that difference, and it is manifesting also because the beginning LDL was 85 and it came to 68. So the
68.
reduction was not that great. It was hardly 22-24% reduction, which neither fits with the treated to target or high dose statin. So may not have translated into the difference in the outcome.
I think the only thought process it can generate is a patient who is pre-diabetic and he needs high intensity statin.
Yes, I agree there. I think we are losing you again. There is some connectivity problem
Right,
at your end, Dr. Javir. We're losing again.
help for that. Sir, there is another question, a very pertinent question that is coming in. This is with regard to the combination therapy, statin plus ezetimibe. So in such patient population, post ACS specifically, uh, going up with the combination therapy instead of choosing the high intensity statin. So
Let me just try to explain. So there are two steps that one has to follow after this once you decide to start a statin. Let us believe that it is acute ST elevation myocardial infarction and you have chosen a high dose statin. Now you also know that high dose statin will reduce the LDL by 50%. You also want to bring the LDL to less than 55 as per the current guidelines. So, and you also know that ezetimibe will reduce 10% more. So a combination of statin and ezetimibe, high dose statin and ezetimibe will produce 65% reduction, right? 60 or 65. Now, what will you do depends upon, in this particular patient who is ST segment elevation, where the objective is to bring it to less than 55, is what is the starting LDL? If a starting LDL is 80 milligram, I would use high dose statins alone because that will bring my LDL to 40, which is well within 55. But imagine the starting LDL or not of 80 but 150 or 160. Then if it is 160 by statin, I would bring it down to 80 and then another 10%, let us say another 10 milligram, that brings it to a target of 70. That is not where I have to go. So I would be using atorvastatin plus ezetimibe as long as the LDL is somewhere around 130, 140. If it is more than 150 baseline and the patient is a STMI, then I may be thinking in terms of using another drug upfront
PCSK9.
or going for PCSK9 at the same time, because I know the limitation of statin as well. So baseline LDL of, let us say, 120, I would use statin. Up to 110, 120, I would use high dose. If it is 140, 150, I would use upfront statin and estimide. And if LDL is more than 150 in acute ST elevation MI, I would go upfront with the statin and PCSK9. That is how I. What is your opinion,
I
Dr.
fully
Raj?
agree. I fully agree with you, sir. I'm also quite aggressive in this regard. I also, if the initial statin is quite high, sorry, initial LDL is quite high in ST elevation MI, I straight away go for PCSK9 inhibitor plus high intensity statin. And maybe after 3 or 4 injections, LDL level may come quite dramatically down. In all my patients, what I've seen is by 1 month, it comes below 50 easily. Then the statins may take over, because statins and ezetimibe may take time, at least 4 to 6, to reduce the LDL cholesterol. And if the target is, if our statin plus ezetimibe, as you rightly pointed out, can reduce it by only 65%. So if the LDL is 200, no way it can take this
No.
LDL down to the target level. So I also fully agree with you. This is the
Yeah.
Yes, Dr. Sandesh.
Yeah. There is another question, sir. And what is your LDL-C target threshold for stable CAD patients with multiple metabolic risk factors?
So if it is if the patient is a known case of coronary artery disease, again,
Right,
my
sir.
target will be 50, even lesser than 55, going to 40 probably.
Mhm.
If it is only coronary artery disease, less than 55, coronary artery plus other atherosclerotic events, less than 40.
Okay. Yeah.
The Lipid Association of India is saying if there are recurrent events, you should go below 30 milligram per deciliter.
Below 30. Yes, one can think about that. One can think about that
There,
also.
I think statin or statin plus ezetimibe alone may not be able to reduce
Yes,
the LDL cholesterol to that target. Then we may require a PCSK9 based therapy.
upfront probably. I think very quickly another drug which is coming may replace PCSK9. The 2 weekly injections may be replaced by 6 monthly injections. Let inclisiran come over and come and take over. And this may probably make PCSK9 as redundant, because nobody wants to have 2 weekly injections. So there, something will change in coming 1 or 2 years very rapidly in lipid management. Another kid on the block is managing LP little a. That will also I think, simplify or complicate. We can say both things, because inclisiran is going to take care of both the things, or newer molecules like pelacarsen and all these, they are going to take care of both the things. So I think the management of lipid in coronary artery disease is in for a huge change in coming 5 to 10 years time down the line. Probably we may not be talking about statins. Who would like to take one tablet per day and have face a risk of diabetes and all sorts of muscle pains and bony aches? One may do away with once 6 monthly injections. So till that time, we'll keep on discussing high dose, moderate dose, and the molecules statin would keep on selling. But I am foreseeing in 2035 we may be talking of something else, and we'll be saying that which patient should be given statin.
Right, sir. Because the world is shifting towards the injectable therapies.
Yes.
And even they are thinking of gene editing, so that there is only once the therapy is given, then it is for the lifetime. You keep the LDL cholesterol low. So a time may come when when the child is born, just like vaccination, they look at his atherosclerotic cardiovascular disease risk and go for the gene editing therapy, so that his system will remain, his or her system will remain exposed to the lower level of LDL for the lifetime.
Till that time, Dr. Sandesh, we still say that either high dose statin or a moderate intensity statin, whatever you want, try to bring it to your whichever therapy is able to reduce it to the target. Choose that and keep in mind whatever whether the patient is prone to have new onset diabetes or not. And I would request Dr. Javed to give one last, let's say, lesson for the home as well.
The lesson for the home says that this data is not whatever the data I have present, the lodestar is not sufficient to change our practice, to move from high intensity statin to moderate intensity statin plus aceclidine. This may be considered in a small subset of patients who have very high risk for diabetes, and at the same time need statins and other drugs to keep their LDL cholesterol level low to protect from ASCVD. This is all what you can infer from this data.
Thank you. Over to you, Sandesh.
Yeah, so thank you so much, Dr. Dwivedi and Dr. Abdullah Kutti. So on behalf of Nexa Division of Intas Pharmaceuticals, I extend my heartfelt gratitude to all of you for being a part of this enriching session of Lipitas lecture series. A special word of thanks to our esteemed speaker, Dr. Abdullah Kutti, for his insightful presentation. Although we had lost Dr. Abdullah Kutti in between because of the technical glitch. But thank you so much for your thought-provoking perspectives on lipid management and cardiovascular risk. Your expertise and clarity have added immense value to our today's discussion. And we're also very grateful to Dr. Dwivedi for chairing the session and for steering the session with such depth and direction and pitching in between during that critical time when we lost Dr. Blackwood for some time. Your presence and guidance have been truly instrumental, sir, in bringing focus to the key clinical takeaways. And to all our attendees, thank you so much for your time and engagement. And we hope that this platform continues to support your clinical practice with meaningful science and with expert collaboration. So wishing you all a very pleasant evening and very good night. So thank you so much all. Once again, thanks a lot.
Thanks, everyone. Thanks.
Thanks. Thanks.
Thank you, sir.